Hi, you guys. Welcome to Ask the Egg Whisper. I love doing this show. I love being here, and I'm so excited to be here again answering your questions. And you guys asked so many awesome questions, and I'm excited to be here again tomorrow, and I'm going to come back on Thursday. I have Dr. Zahira Murhi coming on tomorrow, and we're going to talk and take so many of your questions. So gather around and feel free to chat questions live here, and I'm just going to start answering them now. Okay, so the first question is from Maria. Hello, Dr. Aimee. I recently started watching your show and I absolutely love it. Even my husband, who happened to overhear a bit of it, thought that the information was extremely useful. Why, thank you, Maria. My question is, when should we ask for a sperm DNA fragmentation test? We had our first failed IUI in September, and during it, my husband's semen analysis was significantly lower at 6.3 total motile pre-wash count than the semen analysis that we had done pre-treatment, which was done at a different lab. We've also done a daddy kit test in June 2019, and the results were also really low. Total motile count, 3.8 million. He's now undergoing more testing with the urologist, including an ultrasound, a physical exam, and a repeat semen analysis at the same lab. The outcome of current testing would either mean we try more IUIs or move on to IVF. Okay, Maria, so you know my approach, diagnosis before treatment, and it sounds like the diagnosis is a fertilization issue that's most likely sperm-driven. You've certainly done your very best. It sounds like you've done testing, even as far back as June of 2019. So you guys all know I'm full of great mnemonics. At least I'd like to think I'm full of mnemonics. Get that? It's supposed to be a joke. So Ball's method is one of those mnemonics. The B stands for background genetics, and that includes the sperm DNA fragmentation test. Looking at a carrier screen, chromosome analysis, depending on how low the count is. I would do one just because you don't want to go into IVF not knowing everything. IVF is such an involved process. I'd be pretty pissed off if it were me and I did IVF and found out all the embryos were abnormal, and it turned out that I could have known that there was a higher chance for that because of a chromosome issue. Then we have anatomy, so rule out a varicocele with this urologist. Look at lifestyle, labs like testosterone levels. Sometimes a low testosterone can cause a low sperm count, and there's an easy way to fix it, like taking medications like Clomid, Arimidex, even HCG shots. When I tell a guy to take Clomid, it's really fun to see his face. And I'm like, yeah, it's actually a thing. Don't take testosterone if your testosterone levels are low. That's not good for sperm. And then lastly, think about sex life and sex drive, and there are things that you should do ahead of time, especially before an IVF egg retrieval, so you don't have a sperm emergency. Sperm emergencies are no fun at all. So to answer your question, Maria, I would do a sperm DNA fragmentation now. If you just go to Google SCSA sperm DNA fragmentation, you'll find a do-it-yourself test, and it sounds like you're really good at doing that because you've already done the daddy kit. And then you can also track the semen analysis and then talk to your doctor about doing Pixie, Zymote, combination of the two, and then take supplements and then see what will happen with your IVF cycle, and hopefully only good things. The last thing you want to do is find out after an IVF cycle that it didn't work, and then you do a DNA fragmentation test after the fact, and the DNA fragmentation showed fair to poor DNA integrity of the sperm, and there are things that you could have done ahead of time to fix it, like taking steroids, taking supplements, fixing a varicocele, all that stuff that guys are scared of, because whenever you say needle in the balls, they start running away. But as women, we get needles in our ovaries and we don't complain, and we keep showing up for more until we're successful. So guys, plug your ears when it comes to talking about how you remove a varicocele. Okay, this next question is from Andy, and Andy says, hi, Dr. Aimee. In 2009, I went to my doctor complaining of heavy, long, and irregular periods. He sent me for an ultrasound that revealed cysts on either of my ovaries. He didn't do any hormone testing at the time and simply said I have PCOS. My BMI then was close to 27. Fast forward to today when we're trying to conceive. I've had an ultrasound on day 12, no cysts. My male hormones are all on the low end of normal. A fasting glucose insulin was perfect. My BMI is 22. I'm still having irregular periods, but except for one questionable month, I seem to ovulate each month as tracked by BBT, which stands for basal body temperature, and Prove kits. My question is, had I been misdiagnosed with PCOS? Is there anything else I need to check? I had started taking Ovasitol in May before all the blood tests, but my RE told me I didn't need it. I should also mention that I was diagnosed with Hashimoto's thyroiditis in July, and thank you. Okay, Andy, so this is the thing. You can have PCO appearing ovaries and not have PCOS. And 14% of young women, 14 seems like a really random number, but I swear there's a study that showed 14% of women in this study were found to have PCO appearing ovaries but didn't have the diagnosis of PCOS. So yes, you can be misdiagnosed with it. That's why I call PCOS, please confirm this ovarian syndrome. right? And I also call PCOS hope syndrome. So a lot of people think of PCOS as something that causes infertility, but I think of PCOS as a blessing. It is an opportunity to learn about your body, be as healthy as possible from a very young age, and then constantly maintain that really healthy lifestyle. And a lot of women with PCOS have a lot of eggs, and that's never a bad thing, right? Just like money, you can't have too much. Someone taught me that. Dr. Victory said that the other day, and I thought that was pretty funny. So I thought I would use that today as well in sharing with you about PCOS. But when it comes to PCOS, I think of high testosterone levels, which is H. O is ovaries with lots of follicles on them. P, periods that are irregular. And then things that you need to think about are eating and exercise. So that's why I call PCOS hope syndrome. So I would dig deep and figure out if there's anything else that you're missing. Look at your prolactin level. And certainly you could have lean PCOS. And in cases like yours, sometimes just taking a fertility pill like Femera to help you ovulate in a more regular way can help you guys get pregnant. Look at the tubes, look at the sperm, do your whole Tushy check. Go to tushymethod.com if you have no idea what I'm talking about and learn more there. Those are the 5 tests that every fertility patient, in my humble opinion, should do before they start treatment so that you know what your diagnosis is before your treatment. So this next question is from Marcy. And Marcy says, "Hi, Dr. Aimee. I've learned so much from your show." Thank you, Marcy. "Most importantly, I've learned to advocate for myself, and that's exactly why I'm here." So thank you for that. Here's my question. I'm 37. We've been trying to conceive for 10 months. My husband has slight male factor infertility issue. We decided to try IUI this cycle, and I took 5 milligrams of letrozole day 3 through 7. However, at my monitoring ultrasound, I had 1 leaf follicle at 24.5 millimeter, and the doctor suggested we cancel the IUI to save money because there was a likelihood of having a post-mature egg that would not fertilize. She also suggested that this might be evidence of poor egg quality and recommended we move on to IVF. What do you think? My AMH is 2.38, FSH is 8. I have low testosterone, DHEA is normal, sex hormone binding globulin also normal. Okay, Marcy, this is the thing. Egg Whisperer Golden Rule Alert. Time for me to share that with you. If you're 37 years old and you want 2 kids and you're partnered in a situation like this, I would say do IVF. Freeze your embryos, preserve them. Because you know that myth that people talk about, like just get pregnant with baby number 1 and baby number 2 will be easy. There's a reason why we call that a myth. It's a myth. It's not true. It's not real. And I wish getting pregnant was easier as we get older, but we don't age backwards. So in a case like yours, I would take your doctor's advice, but not because of that post-mature egg thing, not because ovulating 1 egg on Femera means that there's a fertility issue. It's just because I want to take advantage of your youth and your healthy eggs. If I had a room here of 40-year-old women, they would all be saying, "Marcy, go do IVF." And so I'm here on their behalf, shouting at the top of my lungs. Well, not necessarily shouting, but just basically talking to you about the reality of ovarian aging and how lucky you are to be able to have these options at 37 with such an amazing AMH. So I would say go for it, make your embryos, and you don't necessarily have to use them. Maybe freeze and store them. And then consider doing IUI or trying naturally for about 6 months to a year before you use your embryos. I've certainly helped patients with that as well. So your priorities should be your doctor's priorities, not the other way around. So if you were one of my patients and you said to me, "Thanks, but no thanks, IVF, not for me," then I would say that I'm going to try and be more aggressive with helping you ovulate more eggs so that we can give you the highest chance of having 1 baby. And just taking 5 milligrams of letrozole just for 5 days, I would tell you that most people would ovulate just 1 egg. So in my experience, using 3 to 4 tablets per night for 5 nights, and even adding injectables, and I call that a hybrid protocol, might be something that you want to consider doing, and talk to your doctor about that too, if you don't want to do IVF quite yet, and that's totally okay. So this next question is from Allie. Allie is saying, "Hi, Dr. Aimee, I'm heading into an FET and my lining has never gotten above a 6.7 in the past. It's always trilaminar and healthy looking though. My ultrasound during this FET cycle and my lining is measuring 4.9 millimeters. I'm going back next week. What is the thinnest a lining would work for you to transfer? And what are my odds of pregnancy with a genetically normal embryo if I can't get my lining above 6.5 to 7? Okay, Allie, this is the thing. Not having a transfer because your lining is thin is super disappointing, but let me tell you, finding out that you had a negative pregnancy test, that sucks. And I lived through that. I lived through that because I'm the one making those phone calls. And it hurts me. And I had a patient say today, like, "Dr. Aimee, I think this is affecting you more than it's affecting me." And I'm like, no, we're okay. We're okay. I promise. We're okay. We're okay. But the reality is that every negative test sucks. Positive tests, of course, are the most amazing thing ever. But a lot of being a fertility doctor is helping patients through the stress of a negative test and helping them figure out what to do next. So if your lining is not getting above 6 millimeters, for me, I would say re-strategize, figure out a different protocol and option. Let's see what your lining was during your fresh IVF cycle and see if we can mimic that. Look at things like the possibility for scar tissue Asherman syndrome. Figure out, is there something with your BMI, for example, that could potentially be causing the thinner lining? Do you need to gain weight? Do you need to lose weight? Those are all the things that we would talk about. What can we do to bring blood flow to your uterus? Consider things like even acupuncture. I've seen it work before. It's certainly not for everybody, and I wouldn't acupuncture shame anybody. But there's so many different protocols and ways to get a thin lining thicker. There's supplements like vitamin E and L-arginine and aspirin. And I know there are other doctors that, use things like Viagra. I haven't really had much luck with that in my practice, so I don't necessarily use that. But I would say if you are in a position to have many embryos, then I would say you could transfer with a thinner lining if your lining is trilaminar. However, if you're someone who's worked really hard for the same number of embryos as the family size that you want, I would say take pause and re-strategize and figure out other protocols that can help you have a thicker lining. Great question. So this is from Lauren. Lauren says, "Hi, Dr. Aimee. I am planning to start my first IVF cycle at the end of this year. I feel okay about doing the shots for stem. However, I have seen the PIO needles all over Instagram and I'm concerned. Those needles are huge and definitely have me a little freaked out. Are there any options besides PIO? For those of you who don't know, that stands for progesterone in oil, and the needles are huge, that I could discuss with my doctor. Any tips you have for PIO injections? Thank you." Okay, Lauren, I totally do. Tips for injection. Number 1, warm the shot up. You can take the syringe after you've drawn it up, put it in your armpit. Don't stick the progesterone oil in the microwave. I promise you that is not a good idea. You can even take the syringe and sit on it and warm it up for a little bit. I've even had people make a little like a snuggie for their, heating pad snuggie for their progesterone oil syringe, where they roll it up in a heating pad and get it nice and warm, and then you attach the needle. I've had patients sit on ice first, and then after the shot, they sit on a heating pad. I've had other patients use a vibrator. That's probably what it really was. But one of these hand massagers that vibrates and you just vibrate over your butt after the injection. I've had other patients that tell me that using a foam roller and rolling their butt out afterwards, or even doing squats, can really help. So there's so many different things that you can do. But my tips are, make sure you're giving yourself the shot in the right place. So I have lots of pictures in my butt on my phone. In my butt. I have lots of pictures of butts in my phone, and I'll tell you why. Because I have patients who are like, "Can I send you a picture of my butt?" I'm like, "Sure." And I usually delete them, but sometimes I don't. I'm like, butt! Oh, delete. So what I tell my patients to do, believe it or not, I'm like, yes, send me a picture of your butt, and I'm going to make a mark and circle it and then send it back to you, and you make sure to do your shot there. But of course, we have Sharpies in every room in my office, practically, and I'm constantly drawing on people's butts. I should really make a temporary tattoo that just slap it on the butt and it stays there the whole time, so you know exactly where to do the shot, because it is true that shot sucks. But as far as Endometriosis, those are the inserts that I use. I call them Vagiseltzer. They come with an applicator and a white tablet, and I tell patients 3 times a day, you skip one and your efforts are done. So you cannot skip one. You cannot let more than 12 hours pass between the last one and the first one in the morning. And my strategy for success, not sex, success is 8 a.m., 2 p.m., and 8 p.m. And sometimes I add a fourth one, so 8, noon, 4, and 8, and then a progesterone oral capsule. It's a lot of progesterone. And then one in the butt. No, I'm just kidding. I just had to say that because it sounded funny. I've actually had a patient ask, "Can I put one in my rectum?" I'm like, "No, you cannot. That's so wrong." And she actually told me that she read it online, that people were doing that. I'm like, "I'm sorry, those are trolls. Those are people that hate fertility patients. Anyone that would tell you to take endometrium and put it in your rectum sucks. And you should unfriend, block everything and anything you can do. They should not be your friend." Okay, moving on. Thank you, Lauren, for that question. So this is from Leanne. "Hi, Dr. Aimee. A little history. I just turned 38. My 2-year-old daughter is the beautiful result of my second round of IVF. My last blood results show FSH10, AMH1. My follicle count is usually 5 to 7. This year we've done 2 more rounds of IVF and just got 3 mature eggs both cycles. Both cycles we had 6 follicles in range pre-retrieval. We transferred 1 on day 5, then the next on day 3, but neither stuck, unfortunately. My question, should I consider mini IVF for our 3rd and final attempt? Or do I try one last cycle with testosterone gel and DHEA in the lead up, as my doctor has suggested this could help? So Leanne, this is the thing. Your doctor knows your body really, 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 really well. And I would say my recommendation would be to repeat your FSH and estradiol and your AMH and see what's going on. Because it seems like the numbers might be a little bit inconsistent with what you're seeing clinically, and it's just helpful to kind of see how things balance out right now. I would also take, and you guys have heard me talk about these supplements before, True Niagen. NAD is basically the name of the supplement that's in the bottle, and then pterostilbene, it starts with a P, and then make sure you're on a good prenatal with fish oil, vitamin D, and CoQ10. And I would also talk to your doctor about HGHC if that's something that they have experience with and feel good about using. I personally, I'm not a big like testosterone gel and DHEA kind of person, but that doesn't mean that it's not going to work for you. So I would say try it. But this is the thing, when you do IVF, don't do it just to do it. Do it because the cycle looks amazing and awesome and you feel really good about it. So you can always say, look, I'm going to start a fertility treatment and let's just try this testosterone thing and see what happens. If you love like how the follicles look and how they're growing, then I would say continue. But if it's like, not so much, stop it. Just say, this is not working. I hate that label, IVF cycle canceled. I like the label, IVF cycle just not working, right? That seems a lot easier. Seems like a little less stressful than worried about that word canceled. That just seems so like, canceled. I just don't like the word canceled. I don't know. Maybe it's something from my childhood. I'll blame my mother. So this next question is from C. C is asking, what is the truth about having a baby at 44? Is it still possible? Have you had it happen? What's the percent? Age sucks, I know. My levels, FSH 9.5, AMH 1.2. Am I wasting my time to try at least one IVF? I don't want to have regrets. One doctor said no and was pretty uncaring. Another doctor said she'll try, but it's a slim chance. Would you try? See, I wouldn't just walk to the fertility clinic. I would run, and I would run to the first doctor that's super excited to help you. I'm one of those doctors. I'm one of those doctors like, holy smokes, at 44, your AMH is 1.2. Holy beep, get your butt in here. Let's start shots right away. Start your supplements, consider HGH, make sure you're living the healthiest lifestyle possible. Make sure that sperm is really good. Put that sperm through a sperm boot camp as well, because you don't want crappy sperm with your amazing sparkly eggs. One of the mistakes people make is they just move forward with an IVF cycle and they assume that everything is egg driven, and then we forget about the sperm part. And each of your eggs has a small chance, it's true, of being genetically normal, but if anyone has a chance, it's you. So certainly take full advantage of what science can offer you. And I would say, if you're going to regret not trying, please try. When it comes to deciding between donor eggs and your own eggs, I tell people this very simple thing. I say, look, if you do a cycle and it didn't work, would you wish you had done donor egg? If the answer is, I would have rather have just done donor egg, do something that's going to work, than use my own eggs, then just do donor eggs. But if you're like, yeah, I would always wonder, like even if I did donor egg, I would always wonder if it would work for me. Easy. Try with your own eggs. You don't have to do IVF either. Like just consider, like I said before, just try fertility treatment, see what happens, see how the cycle goes, see how it makes you feel, see what you think. And then if you want, don't do the IVF part, don't do the effing, just do the IUIing or just the timed intercoursing. See, I'm making up new words, you guys, who knew? And then you could do that and see what happens, and then consider other options if it seems like it's not working or if it doesn't make sense to you. So I hope that makes sense. That's kind of my algorithm as to how I help patients with their decision making. This question is from Lee. Hi, Dr. Aimee, I'm 36 and I just got my meds ordered for my first IVF cycle. When I initially spoke to my doctor, she said that I would be using Menopur, sorry, it's French here, Menopur, that's how we call it. I mean, it is as expensive as very expensive. I mean, seriously, you guys, think about it. One Menopur vial is like more expensive than a bottle of wine that I would ever think of buying. It's like $90. Like who buys $90 bottles of wine, especially right now in a pandemic? So we should call it Menopur and treat it like the finest wine, as opposed to low dose HCG. But I just learned that my protocol is now with low dose HCG and no Menopur. What the heck? Is one preferred over the other in certain circumstances, or do they perform the same? I'm 36 years old with an AMH of 3.4. Menopur is covered under my insurance, so cost shouldn't be an issue. Thank you. Okay, Lee, this is the thing. I have some news for you. Okay, the people over at Fairing, so that's the company that makes Menopur. So you see these little water vials? See that? They have these little cappies on them. Okay, there's a shortage of those cappies. There's a shortage of Menopur. So a lot of doctors are deciding let's just not deal with the Menopur shortage and not stress out about it, and let's use low-dose HCG instead. But see, I got a guy that gets me Menopur. So I don't have to worry about that stuff. I'm kidding, kind of, but not really. So yes, I've definitely seen people switching over to low-dose HCG, and in a lot of doctors' hands, it works really, really great. There are a lot of doctors who just use low-dose HCG, and they love it. So the answer to your question is no big deal. I really don't think it's a big deal, low-dose HCG or Menopur. But, in my practice, I use Menopur, and I've had no problems with the shortage at all. Thank goodness. Okay, next question is from Pamela. Pamela says, I'm 34 years old with an AFC of 12. AMH is 34.6 picomole per liter. All hormones are normal. HSG is clear, and I have unexplained infertility. My hubby with normal sperm, no DNA tests, we're both healthy, normal BMI, good diet, take supplements, no natural pregnancies for 2 years. 2 failed IUIs with letrozole. Okay, let's turn that around. Let's say 2 IUIs with letrozole that didn't work, because, girl, you're not a failure. 2 failed IVF cycles. Okay, remember, change the language. Language, darling. 2 IVF cycles that didn't work with short and long Lupron, both 150 Menopur and 6.6 of another drug. Stem day 8-9, 10,000 HCG, follicle 16 to 23, first cycle 15 retrieved, 6 immature, 4 abnormal eggs, 5 mature, 2 fertilized, 6 day 5 BB blast mosaic, and a day 7 BC abnormal. Second cycle 12 retrieved, 2 immature, 3 abnormal, 7 mature, 3 fertilized, 2 blast, both day 6, 5 BB mosaic, and abnormal again. Suspecting poor egg quality, trying mini IVF around 3. What would you suggest? Why would I have poor egg quality? Thank you. Okay, Pamela, this is the thing. You're 34 years old and you keep getting these mosaic embryos. Has anyone told you that mosaic embryos can turn into beautiful babies? I wouldn't be tripping. Mosaicism is something that can happen. The fact that it's happened to you so many times might make you wonder, is there something with your DNA? So look at the chromosome that your embryos are mosaic for. I'm sure you've already done this, but do a post-test consult with a genetic company that you worked with for analyzing the DNA. Get a separate genetic consult with someone that's not affiliated with the genetic testing company. Talk to your fertility doctor about their experience. And if they're a doctor who has never had an experience transferring a mosaic embryo, find another doctor, that's me, who has experience transferring mosaic embryos, and I can share my experiences with you. And hopefully that will all help you with making a decision as to what to do next. Because I've definitely had patients that are like, I'm not doing a 3rd cycle. Let's see what's going to happen with my mosaic embryo. And certainly you have to be prepared for all possibilities, a negative pregnancy test, a biochemical pregnancy, a clinical pregnancy that might end in a miscarriage, and then obviously a healthy baby. So as far as suspecting poor egg quality, I would say support your egg quality. It sounds like you're doing everything that's in your control, but certainly consider the supplements that I'm always talking about in different protocols to see if that would help. At the end of the day, I can't change the DNA of an egg. I like to I like to believe, I do talk to a lot of eggs here in the office. I get pretty excited about eggs and embryos. Can you blame me? It's pretty fun to do what I do. But at the end of the day, I've had cases just like yours. I would say that with the number of mature eggs that you're getting, I don't know that a mini IVF is necessarily something that I would do, because I would still try to grow double-digit eggs to get the beautiful number of mature eggs that you're getting. The first cycle was 5, the second cycle is 7. Talk to your doctor about what else they can do to increase the number of mature eggs, potentially pushing you 1 extra day, maybe a dual trigger, adding Lupron to your trigger shot too. These are all things that I've done before for my patients, so I hope this will help. And make sure you've done enough genetic screening. Great question, Pamela. This question is from Krupa. Okay, so Krupa says, hi, Dr. Aimee, I'm 38. My AMH is 1.1. I have moderate endometriosis and have recently had to have my tubes clipped as I have blocked tubes due to scarring. I'm currently going through my 3rd IVF cycle. I have a poor response to IVF meds and was wondering if my med dosage is too high for me. I'm small and generally lead a healthy lifestyle. I eat mainly plant-based diet and I exercise regularly. Cycle 1, 225 units of gonal F with 225 units of Menopur, 4 good quality eggs retrieved. After 10 days of stin, I ended up with 2 blasts. Cycle 2, 225 gonal, 225 Menopur. I had really slow progress, so I ended up stimming for 16 days and ended up with 5 eggs, not so great quality. Only 1 was fertilized. I went for a day 3 transfer, which was unsuccessful. Cycle 3 underway, stays in 3 units from cycle day 2 until retrieval, 450 units of Menopur. Krupa, I kind of like what your doctor's doing. I actually really like Menopur only cycles. I think what you're going through is really tough. You've been working really hard. I would say diagnosis before treatment. So it sounds like your diagnosis is endometriosis driven, most likely, and causing some issues with egg quality. We can also toss in a little bit of age with that, with your age being at 38. And we know that fertilization is an issue because of the fact that an egg and sperm can't get into your uterus because of your fallopian tubes being clipped from what endometriosis has done to your fallopian tubes. So for that, I'm sorry that you've been through so much. My thought process is freeze more embryos. It sounds like you have 2 blasts already frozen for yourself. And before you're transferring, think through doing implantation testing. Talk to your doctor about different tests you can do on the lining of the uterus before you transfer. Think about an adenomyosis. See if that is an issue for you. Ask your doctor, have you ruled out adenomyosis? And if so, or if not, what can you do to rule that out? What kind of treatments should I be considering before I transfer? And this is the thing. I want you to have a baby with your own DNA. You've already done 3 cycles. You're in your 3rd right now. And I think sometimes people aren't told the answer to this question. And I've taught my patients this question, and anyone who listens to me knows the question. Can you guys share it with me? The question is, hi doctor, what would you do if this transfer didn't work? If the answer to that question is I would use a gestational carrier, talk through doing that now. Because if you've worked so hard and it sounds like you have pretty severe endometriosis, even though you call it moderate, it might make sense because endometriosis can decrease your implantation rate, and you might want to at least talk through other options before you transfer to you. Think about all the possible tests that you can do before you do an embryo transfer. We like to roll dice, not embryos, right? We're in IVF clinics, not Vegas. Although sometimes it does feel a little like Vegas, which I hate that about my job because I hate gambling. So this next question is from Melinda. Melinda says, thank you for being such a great resource and light of hope for so many of us. You are welcome, Melinda. I'm 38 years old. I've been trying naturally for 6 to 7 months with 1 miscarriage and found out that I have a low AMH of 0.34 back in late July. We recently started our first IVF cycle. My AFC was 6. That is awesome, but appeared less during baseline. Now that I'm in the monitoring process, it's taking a long time for my follicles to grow, and I likely will only have 2, hopefully, to retrieve. My REI mentioned it looked like I was entering perimenopause. My question is, what does this mean going forward with future IVF cycles? Will this further decrease my odds of a successful chance at a healthy embryo while I already have a low follicle count? Okay, Melinda, let's think about it like this. Okay, you guys, we all know that there's cycle-to-cycle variability. Your ovaries are telling you, stop it, leave me the heck alone. So listen to your ovaries. I'm telling you, you don't want to just do IVF to do the IVF. You want to do IVF because it's going to be a really, did you get that? Really good cycle. So if your ovaries are like, I think I can, your doctor's talking to you about perimenopause, what the heck are we doing? Let's convert that to an IUI cycle, and let's just not talk about perimenopause. It's kind of a dirty word when you're doing IVF. Let's just think of it as your ovaries are telling you that this is not going to be a good cycle, and let's wait. Yeah, it can really be as simple as that. I've seen it before. I've had patients where I do a cycle. I'm like, what the hell was this? What the heck? We just did a cycle to bank more embryos. We did the exact same thing. And this time, nothing worked out. And if I had had some sort of sign that I wouldn't have needed to go through that cycle, believe me, I would have appreciated that sign. And I've had patients where I have a beautiful cycle, and then the next cycle, there's no response. And then we wait a month, and the next cycle, it's even better than the first cycle. So listen to these signs, you guys. Track and trend your hormone levels. Look at your FSH and estradiol and check your AMH level again. And do that at the beginning of the next cycle and see what's going on. Maybe give yourself 1 cycle off in between. Take the supplements that I always talk about and make sure that you're doing your squats. I just had to throw that in because it sounded funny. I like to squat. I do. When I'm not here on my Instagram show, I'm doing squats with my uterus. Uterus squats is what I call them. Okay, actually, she asked this question, you guys. I totally missed it because it was cut off on the page. Melinda actually asked, we're thinking of taking a break in December and doing our next round in January. Would it be better to not waste another month? And I would say track and trend your hormone levels, look at your follicle counts, and make sure you're doing your cycle at a time which makes sense, meaning it's a time when your follicle count is awesome. That's what I would do if it were me. Okay, this next question is from May. So May is saying, hello, I'm undergoing IVF meds and I've been taking Gonal-f 450, Luvera 75, Cetrotide 0.25 milligrams daily. I got a call from the doctor, and the doctor informed me that I had only 1 follicle growing, 1 egg. My question is this: should I go ahead with my IVF or cancel it and wait? I'm 42 years old, and last year I got pregnant the natural way, but when I had my first ultrasound, it was an empty stack. Thank you. Okay, May, this is the thing. First of all, I'm sorry that you had to find out by a phone call by your doctor that you only had one egg growing. That kind of stuff fires me up. So for those of you guys who are watching this, if you're doing IVF, don't leave the clinic until you ask the following question. How do things look? Are you happy with what you're seeing? What do you think I can expect from the cycle? What am I going to be doing next? When can I expect to get an update? So it sounds like your doctor called you, which is really, really nice. But that's kind of annoying to have those conversations after you've left the clinic. Sometimes it's nice to have them like at the same time. And I get it, not everyone scans their own patients. Sometimes it's with nurses and techs, and those people are very well intentioned. They're awesome and amazing, but they're not able to give you an update. But I just feel like when you're going through something that's so expensive and so personal, when you're taking, you guys, I was trying to say Menopur, when you're basically taking medication that's equivalent to like 4 bottles of the most expensive wine that I would never buy for myself ever. And here we are injecting ourselves with it, and then having someone be like, I'm going to call you at night and then tell you your cycle is not doing well. Like that just doesn't jive with me. Anyways, I digress. So to answer your question, wait, I wouldn't do IVF with just one egg. I would say you guys got pregnant naturally without anyone's help. No one had to be in the room with you. I hope no one. Well, actually, if they did, I don't want to know about it. I know people do lots of stuff these days, but it's like, la, la, la. I don't need to hear about it. But I would say you just never know when you're going to ovulate a golden egg. That last pregnancy that you had that ended up in an empty sac was most likely genetically abnormal. But when it comes to miscarriages, I never want to make assumptions. I still take the angel approach and use my angel method with each and every patient, no matter your age. I don't want patients to just think, oh, it's my age and that's why this happened. It could be from an anatomic issue like a uterine septum. It could be from an autoimmune issue like lupus anticoagulant antibodies or antiphospholipid antibody syndrome. It could be from a genetic issue like a translocation or a thrombophilia. So I actually still just do all that testing even for my patients, especially for my patients who are over 40, because they can't afford to have a miscarriage. I mean, no one can, but when your fertile window is closing because of our age, which is normal for everybody, I don't want to take these precious things for granted, which is the ability to help someone get pregnant with a healthy pregnancy and stay pregnant. So my recommendation for you is get your levels checked, see what your FSH estradiol levels are, look at your AMH, and if it seems like your AMH is like 0.1 or something like that, and one egg is all that you should be thinking that you'll have with each cycle, you might want to know that up front and then, do IVF and consider banking embryos. I've certainly done that with patients. It's a very high stress situation. It's, for me, it's always fun, but I always go in just having that talk with my patient, before we go in. If there's less than 5 eggs, there's a chance that I might not get one. There's a chance I might get one and the other will ovulate. We kind of go through all the scenarios as to what we'll do, because I don't want any, game day decisions. I want to talk through all the scenarios up front, because that kind of stuff can happen. I want people to know what all their options are. For example, like doing an IUI even on the egg retrieval day if someone ovulates. Okay, this question is from Brittany. Brittany says, hi, Dr. Aimee, I'm 33. I just did a cycle of egg freezing where I took 150 of Gonal-F plus another drug per day. I triggered with 8 clicks worth of Ovidrel and 0.5 milliliters of Buserelin. We collected 17 mature eggs, but I had severe OHSS afterwards. For my next cycle, my doctor wants to lower my Gonal-F and only trigger me with Buserelin. I read a study that triggering only with a GnRH agonist like Buserelin, for those of you guys who don't know, that's like Lupron here, results in a lower implantation rate, a lower clinical pregnancy rate, and significantly higher rate of pregnancy loss as compared to when triggered with HCG. Any thoughts about this? OHSS was terrible, but I don't want to go through all this to get eggs that ultimately will be of poor or substantially lower quality. Any advice on a good protocol for next time that would net as many good quality eggs as possible without killing me? Brittany, you said it first. That's the thing. I don't want you to die, girl. I want you to have babies and a family, and I don't want IVF to destroy you. Having severe OHSS and then possibly having it twice? Are you kidding me? No, thank you. But I'm going to share some advice with you. Number 1, whey protein, WHEY. I think I need to have someone sponsor this show. You notice that I have fake sponsors. They're not really paying for anything. They're just my friends. And I tell people that they're sponsoring my show. Whey protein works like a charm. 1 scoop per day, 1 scoop per day up until your trigger shot. Leading up to your trigger shot, maybe like those 2 days before, go up to two scoops. After the trigger shot, 3 to 4 scoops per day until you feel better. My other trick, drip drop, powder packs, add to your water, drinky, Gatorade, G2 Propel, Powerade, right? Salty drinks, coconut water, heating pad, a little bit of Tylenol and Motrin, bromocriptine, Femara, and even ganirelix after your trigger shot. So starting the night of the trigger shot, I have patients continue that. That's my way of preventing OHSS. And you can, believe it or not, get OHSS even from the buserelin or Lupron trigger. But if you're really worried about not using the HCG, I would say just maybe add a little something of the HCG. And what I mean by something, maybe even like 700 international units of HCG. That might help you feel good that you're going to get enough mature eggs. But I personally haven't noticed lower quality eggs, lower implantation rates, lower embryo quality from patients who use buserelin or Lupron for their trigger. I just notice patients that do really well post-retrieval and feel really comfortable. And like you said, without killing me, are alive. I haven't killed anyone, and I'm not going to kill anyone doing IVF. And I say that completely seriously. And the reason why I say that seriously, and I know that I'm not, what's the word that I'm trying to use? I'm not taking this lightly, is because I don't take this lightly. Making sure that my patients stay safe, especially now during a pandemic, is extremely important to me. And that's the other thing, Brittany. Your doctors know that there's a pandemic, and they know that they're seeing a surge in cases. So they want to make sure that you're not going to have respiratory distress at a time where you might also get COVID, because that would just suck for everybody, especially you and your loved ones, because they don't want to see you suffer, and I certainly don't want to see you suffer either. So thank you for asking the question. Okay, this next question is from Ashley. Let's see what she's going to ask us, guys. I was on the pill for 15 years and went off in May in preparation for egg freezing this year, but my cycle has not returned. I did a progestin challenge in September, October, and it worked, but no cycle since. As far as I remember, I had a normal enough cycle in the 5 years before starting birth control. My recent hormone panel and ultrasounds came back normal. I'm trying to weight the pros and cons for waiting for my body to normalize to feel like I can get a better outcome versus the cons of waiting longer and having my eggs diminish in quantity and quality. I'm currently 33 and a half. What's more important, going into a procedure with a well-functioning body or freezing my eggs ASAP? Advice. Okay, Ashley. Listen, what's the diagnosis? I mean, either you have lean PCOS or you have hypothalamic amenorrhea. Either way, it sounds like you have a lot of eggs. The whole waiting for your body to start functioning, I'm not so worried about that. There's a reason why your brain hormones are not balanced enough to induce an egg to ovulate for you to have regular periods. Let's find out why. And I can tell you that egg freezing sounds like the right thing to do. And you don't have to wait. If your doctor, for example, says that you're too underweight and they want you to gain weight, that's one thing. If they say that, you have PCOS and you also have problems with your body size and they think that it would be safer for you to lose weight before you go into an egg retrieval, that's another thing. But as far as what's going on with you, if you did a progestin challenge and you had a period, it sounds like you might have lean PCOS. And like I said at the beginning of the show, that's what I call hope syndrome. And you're blessed to have so many eggs and to know about this now. I don't think the birth control pills hurt a thing. If anything, they helped with lowering your testosterone levels and keeping you from having endometrial hyperplasia, which can happen if you go long periods of time without periods if you have PCOS. So I would say don't wait. I'm not too worried about what's going on with you. And I feel like there are some other ways that you can ovulate in the future when it's time for you to try and get pregnant naturally, but I wouldn't necessarily worry too much about it if I were you. So I hope that helps. This next question is from Wendy. Wendy says, hi, Dr. Aimee. My husband, 32, and I, 33, had one pregnancy in spring of 2019, but miscarried. Tried again naturally, December of 2019, no luck. Began seeing an REI in January of 2020. For those of you who don't know what an REI is, we are fertility doctors. We are not stores selling recreational equipment like tents and kayaks. Okay. I had an HSG, tubes are open. My AMH is 2.67, FSH is 11. Ovulated on my own. I had one polyp removed in May. I was put on Femera. Body didn't have a great response to it. One follicle was ovulated on day 6. I was put on Clomid. 3 follicles in our last cycle, ovulated day 14. Husband's sperm count and testosterone are normal, but on the low end, husband's post-wash count has been between 1.2 to 1.8 million for our 3 unsuccessful IUIs. He was put on Clomid and fertile aid 1.5 months ago. Nurse had mentioned freezing sperm to increase count with IUI. Our RE said she doesn't see much success with that. What do you think? Should we take a break to see if the husband's count goes up? Should we start considering IVF? Feeling defeated. Thank you. Okay, Wendy. This is the thing. If you're 32 years old, you know my thing, the Egg Whisperer Golden Rules. I feel like there should be a chime, a song, something that starts sounding off here. So if you're 32 years old in a partnered relationship, or if you want to be a solo mom by choice, for example, and you don't already have one kid and you're 32, I would say freeze embryos. You guys, we talk to young women about freezing eggs, and here we are talking about someone who's 32 with very healthy hormone levels, except maybe a moderately elevated FSH and a very low sperm count. No more IUI for you. My approach, diagnosis before treatment, let's figure out why the sperm counts are low. Is it a translocation? Is it low testosterone? It sounds like it might be, but could that be from a varicocele that could be easily fixed? Let's look at sperm DNA fragmentation before you plan your IVF cycle, right? So figure out everything about your diagnosis, figure out everything that you can do that's in your control to improve all those things that I just talked to you about, like supporting egg quality, supporting sperm quality, designing an IVF protocol that makes sense, right? Don't forget about ICSI. Think about the sperm DNA fragmentation and how you can improve sperm quality with your ICSI. Should you consider PICSI? Should you consider a Zyma? Those are the things that I talk to my patients about. And then before you transfer, remember, you had a polyp. Those darn things, they can come back. So think about endometrial preparation and what you're going to do to rule out another polyp, and look at those implantation tests that you guys hear me talk about, like the ERA test and the Receptiva DX test, and then go ahead and transfer. Make sure you have enough embryos for the family size that you want. The nurse that's saying freeze sperm, she's on to something. I talk to people about freezing sperm like every single day, and I swear to Almighty God, maybe like 1 or 2 patients a year takes me up on it. Maybe 3 or 4. I'm lying. But I do think that it's a great idea, because if you guys end up having embryos and then you need to do IVF in a year or so, it might make sense to use sperm from now versus sperm from the future. But certainly talk to a male fertility urologist, have them do all the things that I talk about in Ball's method, figure out the diagnosis so that you go into your IVF cycle with all the information that you should need and want. Because the last thing you want to do is an IVF cycle and say, next time we would do this because we should have done this. Like, those kinds of conversations can still happen even when you've done your due diligence. But for the most part, I want you to have all the information up front so that you don't look back and be like, God, why didn't we do ICSI? Or, geez, God, I wish I would have known that we both carried cystic fibrosis before our IVF cycle. So I hope these things that I'm sharing with you guys really help. Okay, so this next question is from Ashley. Thank you for your show. Is there a research that links AMH increases to oxytocin levels? That's an interesting question. I actually don't know the answer to that. You can tell that I don't look at these questions before I start talking about them, because I would look it up, but I haven't noticed a link. Here's my journey for context, all in the same lab. July 2018, age 37, AMH 1.56. April 2019, 3.32. June 2019, 3.49. July 2019, endometriosis excision surgery. October 2019, 0.9. Doctor told me temporary decrease due to surgery. Starting supplements, reduced toxins, August 2020, age 39, September 2020, 1.76, November 2020, 3.3 with a follicle count of 14. My question is about the 2 scores and the 3 range, even before my endo was excised. The only difference I could think of at that time is that I was in a happy relationship and sexually active. Are different hormone levels that are interrelated where increased oxytocin can send a message to ovaries to release more eggs? And the answer to that is I don't think so. If not, can you think of any other reason for the 2 high levels? And the answer is yes. It could be lab variation. It could be just the fact that I call AMH always meandering hormone, and that's what it does, and no other reason. It could be related to your vitamin D. It could be related to some slight changes in your body size. It doesn't look like you were taking birth control pills or anything like that that can cause any type of fluctuation. For AMH of 3.3 at age 39, can the supplements like CoQ10 or ubiquinol 400 milligrams and lifestyle changes help so much? I'm happy but skeptical. Thanks. Okay, so actually I would just look at the actual labs that you were using. If your follicle count is, let's say you said, I think it was 14, I wouldn't expect an AMH of 3.3. I would expect an AMH of 1.4. See, my job, not rocket science. So I would maybe get your lab checked. ReproSource has one of the best and most reliable AMH levels. I also like Quest Diagnostics a lot for their tests. I find that they're very, very reliable. So I would say look at the lab that you're doing your AMH with, repeat it, and then maybe do it on, I know this sounds nuts, but this is the kind of stuff I do and I love it. So have your blood drawn 2 different labs and see. Maybe there's something you're taking like DHEA or vitamin B, for example, that's causing this type of lab variation. And I would certainly just rely on your follicle count, because that seems like it might be more reliable in a case like yours and not so much the AMH. Okay, this question is from Kristen. Kristen is saying, hi, Dr. Aimee. First of all, I love your show and how passionate. That is a good way of describing me. I'm slightly passionate and helpful you are to everyone. I recently just switched clinics. Right before I was about to start my IVF cycle, my husband and I have unexplained infertility. You guys, eye roll please. Yep. And a recent slight male factor. As our last clinic had diagnosis with. My new doctor I just saw last week discovered what looks like an endometrioma, but she isn't sure yet since it was her first time seeing me. I don't have typical endometriosis symptoms, what should we do next? Should we continue to go through an IVF cycle or check to see if there's any endo first? Could this cause problems? My husband and I are both 32, AMH is 1.16, my follicle count was 8 on one side and 6 on the other. What protocol should we do? So it looks like we have a diagnosis. It seems like you have male factor infertility as well as endometriosis. Let's support your egg quality with the endometriosis diagnosis. Let's make sure we can get the sperm to sparkle. Have him see a male fertility specialist and rule out the things that I always talk about, like low testosterone, a varicocele, and make sure that he is going through his sperm boot camp and taking his sperm supplements. I just love saying that. I just think of like a little sperm doing little bench presses, right? Aren't they cute? I think they're cute. So her question is, what should we do next? Should we continue to go through an IVF cycle? And my answer is yes. You're 32 years old with an AMH of 1.16. Endometriosis is a fertility threatening condition. I recommend egg freezing, embryo freezing, or both for any young woman who's been diagnosed with that. It can also affect your fallopian tubes and cause inflammation in the tubes, leading to a hydrosalpinx later in life. So I would strongly suggest with an AMH of 1.16, 14 follicles total, I would do, whatever IVF protocol your doctor feels is a really good idea for you. I would suggest a standard stimulation, trying to get at least 10 mature eggs, and it seems like you have that in your future. And then consider maybe treatment for endometriosis beforehand. You can certainly try a fresh transfer. I'd certainly like to do, or at least offer my patients PGT with a frozen embryo transfer. So see if that's something for you. This question is from Cindy. Cindy is saying, sorry, you guys, I still have patients in a busy clinic, so I have to look over here and make sure that no one needs me. Cindy is saying my estradiol level on day 3 of my period was 130. Okay, are you guys ready for this? Insurance requires 100 or less for IVF. Really? Insurance requires it? Did they go to medical school? Right? Don't I sound snarky? Who made them a doctor? Is there anything that I can do to lower it? For background, I'm 37 and I have had surgery for stage 4 endometriosis. Okay, Cindy, so this is the thing. When you have an estradiol of 130, what that makes me think is one of two things. Thing one, an ovarian cyst, right? An ovarian cyst from last month's ovulation that's still hanging out. Doesn't belong there, but still hanging out. Thing two, early ovulation. So it's very possible that your body is like, hello, ready to ovulate, super early, and maybe I'll pop off an egg day 6. So what I would say is, let's look at your follicle count. Let's look at your AMH. Because if that's the situation where your body's going to be doing that, there are lots of different really cool ways of accomplishing an IVF cycle, and maybe you can trick your insurance. Let me tell you how. Thing one, birth control pills. You guys know, I hate them, but this is actually a scenario where you can use them to suppress your estradiol level. Okay, that's one option. Number 2, mid-luteal stimulation. Yep, what does that mean? Second half of your cycle, you start your hormones about a week after ovulation. And if you have a low egg count, which it sounds like you might have because of stage 4 endometriosis, I can't tell that for sure from what you're telling me. That's what I'm seeing here as a possibility for you. So those are the different things that I would do. Okay, guys, I just finished answering all of your emailed questions for tonight. So I get myself a set of a handful of questions. That was 4 pages of questions. So thank you guys for sending them to me. I'm going to answer them again tomorrow with Dr. Murphy. And then again on Thursday, just me. And I'll probably be wearing my blue dress again. So I'm going to go through your text questions here that you guys chatted live with me right now. Here we go. Question number 1, how can I be sure that my my retained placenta was removed via hysteroscopy? Easy. You can do another hysteroscopy or a saline sonogram, and sometimes you can even detect it on ultrasound without doing that. Marion is asking, how can I be sure that removing retained placenta via hysteroscopy didn't leave the uterus infected? I mean, typically a uterine infection would cause pain, cramping, foul-smelling discharge, and a watery discharge as well, sometimes in a white blood cell count that's elevated. So if you don't have those symptoms, I wouldn't necessarily worry too much about it, but definitely ask your doctor. Ask them, have you ruled out an infection in my uterus? This next question is from Bon. I did my first PGT FET. First beta was 764 to 1189 in 47 hours. Is that normal? It did not double. So the answer to your question is that so that is 47 hours, 15. I'd have to know how many embryos you transferred. If you transferred 1 and it didn't double, I would still tell you that 15% of perfectly healthy pregnancies don't double, and I would just repeat it again. And then if it still didn't double, I would make sure that your doctor is doing an early ultrasound to make sure the pregnancy is inside your uterus. Having a pregnancy of unknown location is kind of stressful, and you don't want to find out too late after an ectopic has ruptured that this could be an abnormal pregnancy not inside your uterus. So it could potentially be an ectopic pregnancy. So every pregnancy to a fertility doctor is an ectopic until proven otherwise. So that's why we're super careful, and we're constantly checking this stuff and constantly talking to patients about ectopic pregnancies and the precautions that patients should be taking and the symptoms that they should be looking out for. So if you were a patient of mine, I would repeat your level again in 2 days and bring you in for an ultrasound as well. But I'm not super worried. I've seen levels like that turn into perfectly healthy pregnancies, but at the same time, I'll be prepared for all possibilities. So this is another question. I have my first IUI tomorrow. What can I do to make sure it works? And the answer is, to make sure your IUI works is nothing. I know that sounds really bad, you guys. But when it comes to IUI, it's a chance for pregnancy. The likelihood of success is around 10 to 15%. So what could you possibly do to give yourself the best chance for pregnancy? You could, let's say, make sure you have a full bladder. You can make sure, let me see here. I don't need that right now. Thank you. You guys, see, I have a full clinic and people are interrupting me and I love it. See, it's super fun here. You gotta love people. Okay, so where was I? I digress. IUI. See, you can interrupt me and I can go right back like that. So as far as IUI, what you can do to improve your chances. So the things I tell my patients to do is have sex up until the follicle check before your trigger shot. We don't want saved up sperm. We don't want old sperm. We just need really nice fresh sperm. Thing 2 is make sure when you go in for your IUI, have a full bladder. Don't empty it. Your uterus is like a lawn chair. When you have a full bladder, it straightens it out. Then you get that catheter right in. If you're someone who has pelvic anxiety, talk to your doctor about that and ask them about taking Valium, for example, to decrease the contractions of your uterus. So those are the kinds of things that you can do to increase your chances of pregnancy with IUI, but certainly there's nothing we can do to make it work. I wish. But making sure you've asked the question like, what made you decide to trigger me when you triggered me? How did you decide my IUI timing? You don't want to ask those questions after your IUI didn't work. Those are the questions you want to ask first. Was my lining thick enough? Is there anything that I can support and promote implantation with? And for me, that would be thinking about things like estrogen, if the lining is thin, progesterone, if I think the patient's a good candidate for it. And for me, most of my patients take progesterone. It's like water to a marathon runner. So this someone's asking, have you heard of concerns with transporting frozen embryos in a cryotip device? And the answer is, I have not heard of that before. Can you show us where else to inject PIO? My butt is so sore. No, I can't. Don't do it anywhere else. I promise you, it's going to hurt so much more. I've heard people doing it in their arms. I've heard of people doing it in their legs, and then they can't walk for days, and it's so much worse than the butt. So don't do it anywhere else. If your butt is sore, talk to your doctor about other options like vaginally and orally, and then giving your butt a break and maybe doing a shot every 3 days. So Archie is asking, when pregnant, can you take melatonin when having a hard time sleeping? And the answer is, I do tell my patients that it's okay, but I also tell them about Unisom and Tylenol PM, but ask your doctor. Don't take my advice. My advice is not to replace the advice from your personal physician. I'm just telling you what I would tell my patients, and that's it. Joyce is asking, dear Dr. Aimee, is it better to do moderate exercise several days after a frozen embryo transfer? Will it help embryo growth? I don't know that moderate exercise or how it can improve embryo growth. It might help with your sanity. So I like walking. I tell patients butt to bed, butt to chair, butt to couch, and rotate, and butt to toilet, and butt to shower. I don't know about your butt to a shower and how that would work, but those couple of days after a transfer, and then certainly you can increase your activity. Dear Aimee, after frozen embryo transfer, what would you suggest testing besides HCG levels? I like to test progesterone if patients are super symptomatic. I also test estradiol as well, so I can reduce the dose of their hormones if they're having side effects and symptoms from the hormone levels. So this is a great question. What are the risks of a twin pregnancy? The risk of a twin pregnancy is preterm labor, preterm delivery, meaning losing the entire pregnancy, losing one of the pregnancies from one of the things I just described. Severe preeclampsia resulting in placental abruption, and again, those things associated with preterm labor and preterm delivery. If a pregnancy is delivered before, I think it's 28 weeks of pregnancy, there's a 50% chance the baby could have cerebral palsy, as well as autism and other issues like hearing problems, vision problems. So there are lots of issues associated with prematurity, and that's because the human uterus was designed to carry one pregnancy to 40 weeks. A 20-week uterus with 2 babies, guess what? Uterus thinks it's 40 weeks. That's why a lot of times the babies come early. And that's really scary. You work so hard for these IVF pregnancies and you put 2 in, and sometimes you learn the hard way that might have not been the best decision. And I've certainly been there before. My strategy is transfer 1 embryo, it doesn't work. Transfer a 2nd embryo, it doesn't work. Then the 3rd transfer, then I will arm wrestle my patients and see who wins, and then we transfer 2. I'm kidding. There's no arm wrestling involved. I do talk about transferring too in certain situations, patients with recurrent miscarriages after IVF. I do think that sometimes it could help, and I've seen that it helps after we've tried all the other protocols, and I never give up on anybody. So I always think that there's always a chance, there's always hope, there's always a way. Next question is, have you had patients that had COVID in the middle of stims or preparing for a transfer? Did they continue with stims? The answer is no. I have had people with COVID and no stim for them. And the reason is, like, what if they get sick and they have problems breathing and now their ovaries are like so swollen? So we usually check COVID a week before transfer, if it's a frozen embryo transfer, and then usually by stim day 5 or 6 if it's IVF. So we have time to stop the cycle if they're positive. Hello, Dr. Aimee. I have 3 miscarriages. What is the protocol you recommend before a frozen embryo transfer during pregnancy in my case? Do you recommend natural or hormonal cycles for FET in the case of RPL, which is recurrent pregnancy loss? So my recommendation is make sure you don't have a septum. Look at the uterine cavity very, very well. Do all the testing that I talked to you guys about in the Angel method, and also be sure to ask your doctor if genetic testing of your embryos is something that you should do, especially because you've had 3 miscarriages, and then talk about implantation testing and if you have adenomyosis and if that could possibly affect your ability of staying pregnant or your ability to stay pregnant. So I know I just rattled off a whole bunch of stuff, but basically I just told you about my egg whisperer diet. So that's something that I want you guys to know about. So Joyce is asking, dear Dr. Aimee, is 1,700 micrograms of folate per day too much during early pregnancy? And the answer is no. Amy is asking, for a patient over 40, do you have a preference for fresh versus frozen? And my answer is, like, it just depends on how many babies you have at home. If you already have one at home and you just want a second, sometimes I'm like, let's just transfer. If you're someone who doesn't have any and you want at least 2, I would say let's bank your embryos and freeze them and test them and make sure that you have enough for the future. So, it's an individualized, personalized fertility care plan that I give every single person. Olivia is saying, is 2% normal forms in a semen analysis too low to conceive? And the answer is no. You can have low normal forms and still conceive. It might suggest a fertilization issue, but again, I would have you go through the balls method and see what you can do that's in your control to improve the sperm quality and do a sperm DNA fragmentation test to see if there's anything else you should also be considering. Mom Art Khan, nice name. Who is a good candidate for mini IVF over a full cycle? What is a mini IVF? So mini IVF is just a lower stem way of getting eggs to grow. If you have a follicle count of 2, I would say let's do mini IVF. If you have a follicle count of 10 and you want to do mini IVF, that's fine, but you're going to be dosed to get only 2 eggs. So that can be kind of frustrating for some people. And I've seen it before where you're like, I had 10 follicles and they only got 2 eggs. I'm like, but you did mini IVF. That's what you said you wanted. So mini IVF is great for people that hate the hormones. They hate how they make them feel. Mini IVF is good for people who have less than 5 follicles because there's no point in giving yourself standard stem, in my opinion, to get just 2 eggs to grow when a mini IVF cycle can help you with those 2 eggs to grow at the same time or at the same rate. Lexi is saying, I have a double uterus. How does it affect implantation? And the answer is it can. People who have uterine didelphys might have a higher risk of having tubal issues, and that can cause inflammation, higher rates of endometriosis, and that can decrease implantation rates. You might have a higher risk of having abnormal implantation. Ectopic pregnancy goes along with that, as well as early delivery because of a smaller horn, smaller size cavity. So someone's asking, has true nitrogen helped your AMH levels? And the answer is absolutely yes. And let's see. Jennifer is saying, would the whey protein help if you're going in for IUI? I'm scared of getting OHSS due to my high AMH. And the answer is yes. Someone is asking, let's see here, would you kindly recommend a book or content summarizing the nutritional goals and required diet to boost fertility? Absolutely. Foodfuels.com. Food, F-O-O-D, fuels, F-U-E-L-S.com. You can go there. Dr. Allison Rogers, friend of mine. Let me take a sip of my coffee. And a little coffee there. A cough with a cough. She shared Food Fuels and how she's a fertility expert for them. And she shared some of the recipes last week when she was on with me. So do check that out. Pav is saying, stage 4 endometriosis, AMH is 2.75 D over R. My doctor is esterase priming. Is that a protocol you would choose? We are doing antagonists as well. Please, can you tell me, so the answer is stage 4 endo, AMH is 2.75. My doctor is esterase. Yeah, I mean, I don't necessarily like a lot of esterase priming, but I know a lot of doctors do. I guess it just depends on what they know about your ovaries. So I think with an AMH of 2.75, I don't know where the DOR diagnosis is coming from because that's a pretty good AMH unless you're outside the country and your AMH is something else as far as the units. So this question is, please, can you tell me what is better for FET, estrogen oral pills or estrogen transdermal patches? I'm getting side effects from the pills, and I would say switch over to the patches. The patches work really, really well. Amanda is saying, got surgery for endometriosis and got pregnant with Dr. Aimee right after. Aw, you, Amanda. You're so sweet. You're so cute. I love you. Okay. How many eggs can I expect in IVF with an AMH of 0.92? So anywhere from, like, say, 7 to 10. It just depends really on what your follicle count is. So Brandless is saying, I smoke cigarettes 2 to 4 packs a week between ages 19 to 32, but I've not smoked at all for the last 7 years. Do you think I caused irreparable damage to my eggs, or did the 7 years smoke free? So the answer, okay, so I see what you're saying. So the answer is, unfortunately, smoking does kill eggs and makes women run out of eggs sooner. So with that amount of cigarette exposure, it is possible that might cause you to go into menopause sooner as well. Given what looks like I don't know what your age right now is, but I would say taking supplements like CoQ10, NAD can really help. And I would say go ahead and freeze embryos as soon as possible, just so that you have options for the future when your egg quality will be lower. So someone's saying, if I'm going to carry my partner's egg, what supplements should I take? A really good prenatal, like Theranetal from Theralogics. You can use code TUSHY, capital TUSHY, for that supplement. Amb52 is saying, I'm curious about how to predict if I'm at risk for OHSS. My FSH is 5, AMH is 6. 29 years old, I'm starting on 375 gonal and 30 low-dose HCG. It sounds high. Do I need to be prepared for OHSS? The answer is, it depends on your body size. If your BMI is, let's say, over 32, for example, that dose might actually be fine for you. If your BMI is less than 25, that might be a touch high. If you're a patient of mine, I would say come on in after 2 days of stim if I really felt like that was the right dose for you. On treatment day 3, I would check just an estradiol, and I would say, do not take your shot until you talk to me. And then I would tell you what your estrogen level was, and I would decide whether you should continue the medications at that dose or drop your dose pretty rapidly. And you know all those tips and little tricks that I shared with you guys at the beginning of the show, so go back and watch that so you know what I would do. Someone's asking if Ovidrel shot improves FET. My doctor gave me the shot after the FET, so it sounds like your doctor is doing HCG support, which is similar to taking progesterone after an embryo transfer. Is an HCG of 32, 13 days post 5-day transfer normal? And the answer is it is on the low side, but I've actually had healthy pregnancies with an HCG that low turn into a healthy, beautiful baby. What's the main difference between Clomid and Letrozole? Clomid makes you crazy, Letrozole doesn't. No, actually, Letrozole can cause some emotional side effects for people, but for the most part, Clomid is much less tolerated. It can cause thinning of the lining, hot flashes, night sweats, mood changes, and severe headaches and depression in people who are already depressed. Just doesn't sound like a good idea to me. So I personally prefer Femara. You'd have to fight me if you want Clomid in my practice. This question is, we do our first transfer tomorrow. Any advice? I would just say make sure you're going into it knowing that you did everything you possibly can that's in your control to give yourself the best chance. Say to yourself, whatever the outcome, I will accept it because I will know that nothing that happens is my fault. Know that you deserve the very best and there's an amazing plan for you, and I hope this transfer works. This next question is, what is your opinion on sex before an embryo transfer? I highly recommend sex if you want to have sex, but don't feel like you have to have sex. Don't Google, should I have sex? Because if you want to have sex, it's okay to have sex because your body is saying have sex. But I don't think sex is dangerous before an embryo transfer. This question is, hello, I got my period 5 days after my second egg retrieval. It's been heavy with clotting and I'm on day 9 of my period, which is so weird. Why could this be happening? Well, that's easy. When you do an egg retrieval, you're aspirating cells like estrogen and progesterone from the follicles that are needed to build a lining. So once you remove those cells and you don't take estrogen and progesterone, guess what? Your lining sheds and your period comes. So I'd say totally normal. That waterfall experience sucks. Take pain meds, use tampons, talk to your doctor about what's next. Create a roadmap for what you need to do next so that you have a plan. This next question is, if I can't make blast after 3 cycles, would you consider day 3 transfer? My embryos make it to day 3, then die off. So I would say, Maria, talk to your doctor about why your embryos aren't growing past day 3. It's usually a genetic abnormality in either the egg sperm. It could even be both. Make sure you've done enough genetic screening like a chromosome analysis to rule out a translocation in both of you. And then talk about other options as well. If this next cycle doesn't work, what else would you do? I think day 3 transfers work really well for people who really feel like they want to have a transfer. I like the idea of a day 5 because it gives you more information. Because if you transfer a beautiful day 3 embryo and it doesn't work, guess what happens? You're like, what did I do wrong? You start to blame yourself. And certainly 8-cell grade 1 embryos can stop growing by day 5 because they're not healthy enough. But if you feel like you really want to get to a transfer, and in your gut, you're like, I just need to put these embryos home or get them home, then I would say go do it. And some labs are stronger than others at doing blastocyst culture. So certainly if your lab feels like that's a lab where you're at, then I would take advantage of what their strengths are and do a day 3 transfer. That's what your gut is saying. Ladybugs is saying, is spotting on letrozole common? And I would say no, spotting on letrozole is not common. If you're spotting, rule out a polyp. Cervical polyp, and uterine polyp. What are your do's and don'ts tips for home insemination, trying to take the pressure off having sex? So for home insemination, I would say take a semen collection cup, Close it up after ejaculation, keep it warm 20 minutes, and take it out. Use a 3 milliliter syringe with a needle, draw it up, take the needle off. Duh, that's an IQ test right there, right? Don't stab yourself in the vagina with that needle. Place the syringe in the vagina and push it in. If the volume is more than 3 milliliters, which it usually isn't, then do it again and place it in again. Pillow under the butt. I have my patented Egg Whisperer pillow coming out soon. That is a huge joke, but is it? And then lie down for about 10 minutes, then go use the shower or wash up or use a peri bottle is what I tell my patients to do. Okay, so Mom Art Con, 38 inches, had our first baby 7 months ago after 2 full cycles of IVF. He was our last embryo. We want one more. When can you start if still breastfeeding, and would you do mini IVF? So my thing is that if you could swallow fertility shots, they would be in pill form. So your baby breastfeeding is not going to get any of those hormones. As your estrogen levels rise, I promise you that your son will not get boobs. I feel like the longer people are waiting to have babies, it is not fair for us to tell women that they need to stop breastfeeding to do more IVF. Certainly the IVF medications can slow and decrease your milk production. You have to be ready for that. And I've had cases just like what you're describing to me. And then after you're done with the IVF, your milk production goes back up. So my suggestion to you is talk to your doctor about what they think is best for you. If you were my patient, I would say, let's move forward with IVF as soon as you feel comfortable doing that. Next question, is there a risk in transporting my frozen embryos to another clinic? I'm very unhappy with my current RE and I want to switch, but I'm hearing that there are risks with transporting frozen embryos. That's really hard. The risks are small. They're certainly not zero. And I move a lot of embryos because I have patients that come from all over the country, world, from, I won't name any countries, but there's a lot of them. You can imagine. Lots of countries and states and clinics and cities. And for the most part, I try and travel to the embryo. I don't necessarily want embryos to move, so that's why I have privileges at so many labs in the Bay Area. But if you really feel like you're not getting the attention you deserve and you want a new, fresh set of eyes, then I would say it's okay to move your embryos. So, you guys, I love you, but I have to go. I have patients waiting for me. So I'm going to stop the questions now. Thank you guys for asking all your live chatted questions. Thank you for sending your email questions. I'm sure you guys know I have a class. It's called the Egg Whisperer School. Actually, it's a class in the school. It's the IVF course. So if you haven't taken one of my classes, it's a great way to ask your questions. It's a more intimate setting where we'll talk on video. It's a Zoom call. And I hope to see you guys there. I do one every 2 weeks. So you just go to eggwhisperschool.com and sign up. And then I'll see you guys there. And certainly I'll be here again tomorrow. And then the next day. And then next week. And I'll keep doing these until there's no more patients suffering from fertility issues. And I know that day will never come. And until then, I'm going to stay strong. I'm going to stay resilient. And I'm going to be as hopeful as possible. And you guys know what hope means. Have only positive and practical expectations. And I'm going to teach everybody every single day how to, oh my God, I just spilled all my coffee. How to stomp out the ants. See, I got so excited about the ants. Always negative thoughts. How to stomp them out. How to think really positive in that moment where you can squeeze your buns. I swear to God, this is my new thing. For those of you guys who are still watching me tonight, I tell my patient, go to your happy place. Do you know what it is? And I just make them laugh because they're like, oh no, I don't have a happy place. I'm like, how can you not? Squeeze your buns, squeeze your buns. And that's a great way of distracting yourself, right? You're getting your blood drawn, you're feeling stressed, your heart rate's like, just squeeze your buns, right? Just focus on something, your butt, right? You're never alone when your buns have each other. Someone taught me that this week. Okay, guys, love you guys. I hope you guys had fun watching me tonight. Watch me knock over my coffee for like the 10th time today. And I'll see you guys back here tomorrow. Have a great night.